Hello and welcome back. This is Adam Rosen. Today I'd like to talk to you about the stiff total knee. This is a updated version of a lecture that I gave previously on the same topic. As we all know, the number of total knee replacements and total knee revisions is continuing to increase yearly. And although the success rate of those procedures is quite good, there are a number of complications that can occur. And the one that we're going to focus on today is the complication of stiffness or arthrofibrosis. So Webster defines stiffness as something that is not easily bent or something that is impeded in its range of motion or movement. And the minimum amount of range of motion that we need is quite low when it comes to most activities such as ambulation, climbing stairs, and rising from a chair. We know that the best predictor of postoperative range of motion is a patient's preoperative range of motion, but many companies have come up with newer high flexion designs in an attempt to improve this motion, and this is something that we can evaluate postoperatively. But how we define stiffness as a surgeon depends on your mentor or the studies and authors that you read. Most commonly, they'll talk about an arc of less than or a maximum flexion of less than a particular degree. Although the incidence of severe stiffness or arthrofibrosis has varied in the literature, for the most part, this is a very uncommon complication seen after total knee replacements. When evaluating the stiff total knee, it's important to have an understanding of where these things may have occurred. In certain patients, preoperative limited range of motion or multiple prior surgeries may be a cause. There are intraoperative technical difficulties that may arise, such as overstuffing the joint or poor balancing or joint line restoration. And then postoperatively, there may be issues with pain, whether or not the patient completes and is compliant with their physical therapy or other etiologies. Luckily for both me and my patients, I've had a very low incidence of stiffness over the years, but I do see a number of patients for second opinion that have severe stiffness following a total joint replacement that was performed elsewhere. I believe that it's these patients that have taught me a lot about understanding stiffness and some of the causes. I believe it's very important to go back through the history and the preoperative physical exam findings prior to their joint replacement, find out how many and what types of surgeries they may have had, and see if you can ascertain what their preoperative range of motion was like. It's also extremely important to get their operative report to understand what things occurred during the procedure, as well as implant sizing. The preoperative x-rays I always also find are important to assess what was the severity of their disease, how much arthritis they did have, and what was their alignment and deformity like prior to their knee replacement surgery. It's extremely important when you examine these patients to get a good assessment of their range of motion and measure this with a goniometer, as well as compare to their contralateral leg whether or not they have a native joint or total knee replacement on the other side. Do they have a flexion contracture? And are they tight in just flexion, or are they tight equally? Is there a mismatch? What is their mid-flexion stability like? And also assess their patellofemoral mobility and see whether or not this is true arthrofibrosis or if this is simply a issue just with flexion alone or simply just extension alone. As with any painful total knee, you want to get a full workup, ruling out things like infection, loosening, obtaining radiographs, and again, like I said previously, I believe it's very important to get preoperative radiographs and immediate postoperative radiographs and compare them to what you are seeing today. Years ago, prehabilitation was extremely important, and then multiple studies came out and showed little or no statistical significant difference. More lately, that has changed once again, and preoperative range of motion and preoperative physical therapy has become important. I talked to especially my younger patients if they recall having an ACL reconstruction, that they did go through aggressive therapy ahead of time to make sure that they obtained good range of motion prior to surgery. And although they may not with physical therapy obtain normal range of motion if they have a severely stiff arthritic knee, any gains that they can get prior to surgery, I find in my patients significantly helps their physical therapy and their range of motion postoperatively. I do not personally use, nor do I know any surgeons personally that still use CPMs on a regular basis. When this was introduced back in the 80s, there was a significant improvement in the range of motion prior to using a cast or days of bed rest. But nowadays, when patients do ask about it, I explain to them that they probably don't want an implant or anesthesia or pain management from the 1980s. Why would you want physical therapy from the 1980s? Now, there's two instances where I find that the CPM may still be used. There's a group of individuals that are stiff following a revision surgery and you try to throw the kitchen sink at them, or patients that postoperatively have a medical complication that makes it difficult for them or near impossible for them to do physical therapy or get out of bed. And I believe that this adjunct is something which is better than nothing alone, but in no way should take the place of modern, aggressive, range of motion and physical therapy endeavors. Now, I have two caveats for young surgeons. If you're a young surgeon going back into an area where everybody else has been in practice and towards the end of their career, and every doctor in town uses a CPM, every hospital uses a CPM, every physical therapist is used to having their patients in a CPM, it may be quite difficult for you to be the person that tries to explain the data and the current research out there to all of those patients and therapists. And if you do get one patient that is stiff, even if you have 99 other patients that did great, everybody's going to believe that patient in your hands got stiff because you didn't use the CPM. So in that case, I would recommend just throwing it on them for a short period of time, again, as an adjunct to physical therapy. The other one caveat, which I find that you may save a lot of time and effort in the office, reminds me of when I was treating pediatric patients, and you had a patient that came in with tibial in-towing, and the mother was there, and the grandmother was there. And the grandmother tells you how her daughter had it, and she had bars as a child, and that the grandmother knows that this young grandchild needs to have the bars. It's really hard to win that battle. So if I have a patient who brings up the idea of a CPM, and I briefly discuss with them why we don't use it, and they accept that, I move on. But you have a patient with multiple family members, and they start berating you with question after question after question. Just understand it's probably a no-win situation, and it may be easier just to explain to them that they shouldn't use this instead of physical therapy, but you'd be happy to order it as an adjunct to their physical therapy that they're going to do post-operatively. So my routine follow-up is a typical patient is in the hospital just overnight, so basically a 23-hour observation stay. We do physical therapy day of surgery, and then twice the following morning, and then home. I do give them exercises in the preoperative setting that I review with them, as well as at the bedside. On postoperative day 1, I review my extension and flexion exercises with them, and we do also use an app-based program, which the patients are enrolled in, and starts a prehabilitation protocol at home, and then gives them different phases of exercise at home. And then they also do get home physical therapy, which most of the patients may only use once or twice. I try to transition all my patients quite quickly to outpatient physical therapy, as I believe they get more aggressive and better outcomes in outpatient than they do in the home setting. And I see these patients back in the office typically at 4 weeks. If someone's progressing well, I see them back in the 3 to 4 month mark from the day of surgery. However, if I do have somebody that I see at 4 weeks, or I get a phone call prior to that from their therapist that someone's failing to progress, those are patients that I will bring back in. I will review once again the importance of extension and flexion. I review exercises with them again, and then I also will have them come back just for a range of motion check in about 2 weeks, just to make sure that they're progressing, with the understanding that if they're unhappy with their outcome, and I'm not happy with how they're progressing, and they continue to be stiff, that the next step is setting them up for a manipulation under anesthesia. And I find that this very cautious observation of them in that short, early postoperative period, with the encouragement that you can give them and the expectation of what they're aiming for, most patients are able to achieve another 10 to 15 degrees in that 2-week interval, which puts them on the road for a better outcome at the end of their physical therapy. Now, I find physical therapists asked a lot of times about dynamic splinting and dynasplints, and in my hands in the past, I've never really seen any benefit with stiff total knees. Now, this might be useful for other surgeries, other injuries, or other joints, but in my personal experience, I haven't seen many success stories with dynamic splinting alone. How many degrees of flexion is acceptable postoperatively, and at what point in time you might manipulate the patient will depend, so you have to develop your own protocol based on the data that's available. For me, if I do see a patient who's failing to progress at 4 weeks, I will see them back in 2 weeks and make sure that they're progressing at least by 10 degrees or more in that 2-week period, and otherwise I talk to them about a manipulation. If someone at 6 weeks is still stiff in my hands, I try to get them into the operating room by 8 to 10 weeks and manipulate early, as opposed to waiting to the 12-week mark or later, where the success rate of that manipulation goes down significantly. We used to have an anesthesiologist that used to love taking 2 tongue depressors, and as you were bending the knee deeply would break these. Definitely gets your heart racing the first time it happens to you. But in any event, I do manipulate my patients, and once again, quite low number. But this is due to a lack of motion, failure to progress. These are patients that say have 85 degrees at 4 weeks and they're not progressing. And this is a patient that had, say, 140 preoperatively. It's very different if I have somebody who's progressing slowly at 85 degrees at 4 weeks, but only had 100 degrees of flexion preoperatively. The expectation for total flexion might be a little less in that patient. And you want to know what the etiology is. Are they developing true arthrofibrosis, or is this a pain issue? Do you have to alter their pain management regimen? And you also want to make sure they don't have other issues like hemarthrosis or infection, which could be contributing to their lack of progression with the range of motion. But I always try to get these done within that 6 to 12 week mark. So if I do have to do a manipulation, I try to set it up early in the day and try to have the patient set up for physical therapy that afternoon. We do general anesthesia, and I do take a pre-manipulation photograph with gravity for documentation, both for them, for me, and for the physical therapist. I do a manipulation, including the patellar manipulation, and then I get a post-manipulation photograph. If they have a significant hematoma, then I occasionally will aspirate the hematoma and inject Marcaine with epinephrine postoperatively to control additional bleeding and pain. And then I always get a lateral radiograph in the operating room just to make sure that nothing occurred, such as a fracture. Now, this is an extremely important thing that I think is helpful for patients, as you can tell someone a number of degrees, but seeing a picture is worth 1,000 words. This is after a manipulation, and I even use this now as a routine basis after my routine primary total knee replacements, where I will take their knee and flex them up, keep the foot on the table, have my assistant hold the leg, and I will take a picture, and I give that to the patient as an incentive. It's also a way of documenting what their postoperative flexion was following the surgery, and I found that this, as one little instrument, has really helped patients push through physical therapy after a routine primary total knee replacement, and one of the reasons I believe that I do not have many patients that do develop stiffness postoperatively. Now, whether or not arthroscopy along with the manipulation has a role for a stiff total knee, you can review a lot of the studies that are out there. One of the things that I've found to be very helpful during my primary total knees is once the implant is cemented in place, I will take the bovie towards the end of the case and go around the superior aspect of the femoral component just to make sure that there is no tethered synovium underneath the flange as you cemented. But you may also see with a lot of these studies an improvement in the range of motion as opposed to simply just doing a manipulation alone. It allows you access to intra-articular structures if they do indeed have a tethered band. So I believe that if you are going to do an arthroscopy, you want to know what you're going to be going after. If you feel that they do have a tethered band or tightness in the gutters, you might get access to them, but deeper in the gutters is harder to access with the arthroscopy. If they do have a cruciate retaining implant, you do have the option of using an arthrocare or similar type device and taking off a portion or releasing a portion of the PCL off the femoral insertion, or even under direct visualization, pie crusting the PCL with a needle. And you want to do these early. I believe that the longer that tissue matures, the less likely you are to see significant benefits with arthroscopy and manipulation. I find that if you have to do it, tourniquet is helpful to limit the risk of bleeding, especially as you manipulate. Now, again, if they do have the cruciate retaining design, you can release the PCL either off the femoral insertion or with pie crusting, but you want to make sure that you don't develop into too much laxity, which would require different components. This is a dist poly or conversion to a PS, which would have to be accomplished through an open procedure. I usually do the arthroscopy first, followed by a manipulation. If they're extremely tight, you can do the manipulation initially, then scope, but you may introduce bleeding at that time from the initial manipulation, and then remanipulate at the end and determine if there's any bands or specific areas where it's tight that you could go back in and release while you're there. But what about in lieu of a manipulation or arthroscopy? Is there a role for an open lysis of adhesions? And I think this is dependent mostly on when you are seeing these patients and how far out from surgery they are, as well as how stiff or how tight they are and what the underlying cause is. I see this most commonly as a second opinion, someone that's 2, 3, 4 years out. They've been extremely unhappy with their lack of range of motion. They failed to progress possibly with aggressive physical therapy or even with a possible manipulation that was performed outside. And now they're coming to me because they don't want to live the rest of their life with this stiff range of motion. The arthrotomy, you have to understand the extensor mechanism is going to be tight, as they are here for stiffness, so you need to protect the extensor mechanism in some way. I typically use a bone tenaculum. Some people will choose to use a staple of some sort, but you do want to be cautious. Now, when you do the synovectomy, I typically do this open, usually rongeur to get some debris, but then you use the bovie and try to get both gutters completely clean and clear. One of the tricks which can be helpful sometimes if you are concerned about taking tissue off the back, I've used an arthroscopic shaver in a dry mode from time to time to take some of the synovium off the posterior capsule cautiously, but I also use a curved osteotome to make sure that we can strip posterior capsule directly off the bone, especially if someone has a flexion contracture. If you are going to be doing a poly exchange, again, you want to make sure you know which implant is in there so you have the appropriate polyethylene inserts available. And then you have to decide if do you have smaller inserts available, or if you release the PCL, say in a cruciate retaining knee, do you have dished options available so you don't have to exchange your femoral component. But you want to make sure that you can expose as much of the knee as you can and go after those areas specifically that are tight. Now, is there a role for isolated poly exchange only? Well, once again, you have to understand what the cause of the stiffness is. If somebody truly is just equally stiff in flexion and extension and is otherwise well lined and well balanced, and there's a thinner polyethylene available, this may be an option. Studies alone looking at isolated polyethylene exchange was quite poor as far as the outcomes. Here was essentially a case series of 7 patients that underwent lysis of adhesions with conversion to a thinner poly. And if you can see, their postoperative range of motion arc only increased from 36 degrees to 58 degrees, so not a significant improvement. Another study looking at a open lysis of adhesions did show an increased range of motion from 55 to 90, which may be more functional for most people. Still not optimal, but a small number of patients. And another study looking at improvements in range of motion up to post-op range of motion of 86, but their average starting at 36 was significantly worse. And they believe that you can actually improve these patients' function. And in my hands, what I found is that if you can be very, very diligent with your exposure and your releases, and you really spend the time in the operating room to define where and what is tight and address those things, that you can actually improve these patients' function. And although it may not be normal or what a routine total knee replacement is, I find that if you can get these people up to 100 degrees, those patients are extremely grateful, and they tend to be quite functional, as even getting out of a chair is difficult with only 90 degrees of flexion. Beyond just the manipulation, scope, and open lysis of adhesions and polyethylene exchange, occasionally a full revision is needed or necessary. But once again, you want to make sure that you understand why you're revising and trying to determine what the etiology of the stiffness was to potentially increase the success rate of your procedure. But because these patients are here for stiffness, you have to understand that their extensor mechanism is going to be tight. So you need to protect the tubercle. You may also need to do a snip or a VY lengthening depending on how tight they are. And with the releases and the synovectomy, you want to be very thorough in the gutters as well as off the posterior femur, especially if those patients had a preoperative flexion contracture. But you got to determine where the tight structures are and release them. And as you do these releases, especially if the tissue has been quite fibrotic, it may not have the normal structural integrity. And to release those things to get range of motion, this may lead to the need for constrained implants. You want to make sure that you have both stabilized and constrained implants available at the time of your revision. I've always been interested in the true biology of arthrofibrosis. You hear about patients that get multiple adhesions from laparoscopic or open laparotomy procedures. Then they have family members that also have adhesive capsulitis in their shoulder, or another family member that had a similar episode with stiffness in their knee. So it makes you wonder what's going on at the level of the tissue with the fibroblasts, and studies have been done to look at this. But we still need more data and research to truly define why this occurs and then determine in who, if they have those particular risk factors or genetic predispositions, how do we identify those patients? And even if you knew that information, is there something that we can do preoperatively, postoperatively, intraoperatively, or with biologics to prevent that patient's biology from causing the arthrofibrosis that they may be at risk of postoperatively? But I believe the best thing that you can do to prevent stiffness in your patients for your primary total joint replacements is to prevent it from ever occurring. So that's kind of using a sports analogy. The best offense is a great defense. If you let your patients know ahead of time how important motion is, they may be less likely to get into trouble. So it's preoperative range of motion if specifically they're a stiff knee going into surgery. 2, making sure that you have a good pain management protocol. Obviously, that you do a good procedure and the knee has good range of motion and is well balanced, and that the patient does their physical therapy postoperatively. The little trick that I told you earlier about, which I believe is an invaluable resource, is just taking that picture at the end of surgery, not only to document their flexion, but to give the patients an incentive. I find that more importantly, when they bend it and have pain, that picture just lets them know that the pain that they feel isn't doing damage, that the knee can bend a little bit further than what they're feeling currently, and keeping a close eye on these patients to make sure that you don't have somebody getting into trouble early. I set the standard with my patients. When they leave the hospital in 24 hours, they should be at 90 degrees. And then every 2 weeks, you should see a 10-degree increase. So if somebody knows it, the first day they should be at 90, at 2 weeks, they should be at 100, at 4 weeks, they should be at 110, and at 6 weeks, 120. It gives people a goal, and it lets them know when they're getting behind the 8 ball so they can play catch up at that point. Well, I hope that this has been helpful and has answered some of the questions and discussed some of the little tricks and tips that you may use should you develop patients that have stiffness. And until next time, I'm Adam Rosen. Thanks for listening.